Hi students, welcome to the first lecture for the first module in pathophysiology. This week our topic is cellular injury, inflammation, and infections. So this is sort of the foundational module that we are going to build upon for the rest of the course. So before we get started on some of the content and different diseases and disorders for this week, just a little background on what is pathophysiology. So the official definition for pathophysiology is it's how diseases and disorders change processes in the body. So the word patho itself means bad. So this is essentially like bad physiology. So in A&P, you learned all about how things normally function. And now in patho, you're going to learn about how those normal functions get messed up and how that causes different diseases and disorders. So patho is a foundation for a lot of your future nursing classes. Students often say that this is their favorite class in Gen Ed because it ties together a lot of concepts and other classes you've learned, and it, quote, feels like nursing. And that's because patho really is the foundation for a lot of the things you're going to be doing in core. So for example, pathophysiology helps you answer questions like, why should certain drugs or medicines be chosen to treat certain diseases? So that would be helpful in pharmacology. Patho is also helpful for knowing which signs and symptoms are important to assess for patient care to help them understand what disease or disorder they might have. Patho also helps you understand which of interventions are appropriate for a patient with a specific disease or disorder. So patho is a really fun class that is going to be really helpful for your career as a nurse. Okay, so before we get into some specific diseases and disorders within patho, we're going to go over some vocab. There is a ton of vocab in patho. There's a lot of memorization you're going to have to do. The pace of the course is fast. We're covering like 4 or 5 chapters every week. It's a lot. That being said, if you know some of this essential vocab, it is going to make the rest of the class so much easier on yourself. So please, please, please take the time in this week to really memorize some of this foundational vocabulary, because it's going to make the rest of the class easier and you're going to help out your future self a lot. So the first essential vocab you really need to know is the difference between a sign and a symptom. So you will see in your learning guides every week that you are going to have to talk about different signs and symptoms associated with different diseases and disorders. So signs and symptoms, a lot of times we'll say them together as like signs and symptoms all as one big thing, but there's a difference between the two. So a sign is something that's found during a physical exam or a lab test. So it's essentially something that you can measure. They're objective, they're not based on the patient's perception. So for example, if a patient is running a fever of 100.4, that is a sign. That is a physical thing you can say for sure this patient has a fever. A symptom is something that the patient feels or experiences. So symptoms can be kind of subjective and they can depend on the patient's description. So a similar example, a patient might report that they are feeling chills. There's no way for us to measure chills, but those two things together, running a fever and they have chills, that's indicative that they probably have some sort of infection. Okay, so that's the difference between a sign and a symptom. So now we're going to do a quick little check for understanding. You will see that I will use these in all of the video lectures that we do. So whenever you see a slide like this that has a yellow background, what I want you to do is go ahead and pause the video and think about the answer to yourself, and then unpause the video and check your answers. So I'll always give you like a second to pause the video, and then I will just go through the answer. So I'm not going to like sit here in silence for 5 seconds as you think through it. It's up to you to be on top of things and pause it really quick. Okay, so our first check for understanding is each example a sign or a symptom? So go ahead and pause the video and then unpause when you're ready to check your answer. Okay, so first one, nausea. So there is no test to measure nausea, right? That is a feeling. So that would be a symptom. Next one, jaundice. That's yellowing of the skin and eyes. That is something that you can see. It's something you can report. So that would be a sign. Excessive urination or polyuria. So you can measure the amount of urine that someone is producing, and if it's more than what is considered the normal range, then that would be considered excessive. So that is a sign. Enlarged lymph nodes, once again, that's something you can palpitate. That's something that you can feel as the provider. set as a sign, whereas fatigue, that is something that the patient reports, so that would be a symptom. Okay, so that's our first set of vocabulary terms, sign versus symptom. We will use these terms every single week. Next, very important set of terms are acute versus chronic. And these are terms about when the disease, the onset of the disease. So did it come on quickly or did it develop over a long period of time? So something that is acute is usually a new problem that has a rapid onset. It's usually very severe and very sudden. So chronic would be a long-standing condition that takes a long time to develop. Sometimes it's months or even years. In general, chronic diseases tend to be less severe, but they also can be harder to treat because of the chronic nature. So some examples of acute versus chronic. So let's say that you jammed your finger in a door and that caused some joint pain. That would be acute joint pain. It's new, it's rapid onset, it happened right away, it's very severe, it hurts a lot. Maybe you broke that finger joint. That's very severe and sudden. An example of something chronic would be if you have osteoarthritis. So that is the arthritis that develops with age. That takes years and years and years of breaking down some of the cartilage and the protective fluid within the joint, and that causes pain in the joint. So that's something that's chronic. Often that pain would not be quite as severe as breaking your finger joint, but it probably also would be a little bit trickier to treat because you've lost some of that cartilage, and so it's just harder to treat something that is caused by a deficit like that. So just an example, but once again, these are terms that we're going to use every week. So acute, new, rapid onset, chronic, long-standing, a slower onset. Okay, check for understanding. So once again, read the question and then pause the video and then unpause it when you want to check your answer. Okay, so this condition, inflammation that occurs rapidly in reaction to cell injury, rids the body of the offending agent, enhances healing, and terminates after a short period, either hours or days. So this says rapidly, occurs rapidly. So this is acute onset. This would be considered acute inflammation. Very good. Okay, and then the last little vocab we're going to talk about are prefixes and suffixes. Like I said, tons and tons and tons of vocab terms in patho, but so many of them use a standard set of prefixes and suffixes. So if you can memorize these, you can logic your way through the meaning of a lot of these vocab terms. So instead of memorizing like 500 different terms for the midterm, you can memorize the 20 prefixes and suffixes in this Quizlet set and then be able to just kind of figure out a lot of those vocab terms. So it's a huge time saver. So where this is, it's in the Quizlet set, which once again, the link is here in the slides if you're in the slides. You can also find a link to the Quizlet set in the helpful resources for Patho website, which is a link that I shared in our first announcement that I sent out on Canvas. Okay, but we're just going to go through a couple of these prefixes really quickly. So the first set of prefixes are about different systems of the body. So you probably know a lot of these already from A&P. So for example, cardio means relating to the heart. Hepata or hepat means relating to the liver. Entero is intestines. Neuro is related to the nervous system. Hemo or hema is related to the blood. Gastro is related to the stomach. Nephro, or sometimes renal, is related to the kidneys. Osteo is related to bones, and myo is related to muscles. You will learn different diseases and disorders that use all of these different prefixes. So definitely worth memorizing now because it's going to give you hints later on in the course. Okay, next set of prefixes, and these are ones you might have seen before, but some of these might also be new. So these are all prefixes and suffixes about quantities or about abnormalities. So for example, tachy means abnormally fast. So for example, tachycardia, tachy, fast, card or cardio, heart, that is an abnormally fast heartbeat. Brady, that means abnormally slow. So these two would be opposites. Tachy is fast, Brady is slow. And then this means bad or painful or difficult. Probably the most common example you might have heard before is dyslexia. Someone who has dyslexia has difficulty reading or difficulty like interpreting letters. So dis just means difficult. Next set, hyper and hypo. So hypo is greater or higher, and hypo is less or lower. I always remember that hypo is low. And then the last set, poly means many or much, like a polymer. Oligo means few or little or scant. And then a or an, depending on what the next letter is, it'll sometimes be a or it might be an. That means not or without. So poly is a lot, oligo is a little, and then a or an is none at all. Okay. And then the next set of suffixes, all of these suffixes are about changes in the function of cells. So once again, some of these you might have heard before, some of them might be new. Either way, definitely worth memorizing to save yourself some time in the future. So first one, so important, itis, I-T-I-S. Anytime you see itis, it means it's some sort of inflammation. Maybe it's caused by an infection. So that makes you think inflammation or infection. That's different than I-S-I-S. So make sure you read carefully that if you see itis, that means inflammation. The next two are opposites. So penia is a reduction in the number of cells, whereas cytosis is an increase in the number of cells. So for example, thrombocytopenia is an abnormal reduction in thrombocytes or platelets. And then thrombocytosis is an abnormal increase in thrombocytes, the number of platelets. So the suffix of that word gives you a hint about what that symptom means, or that sign. All right, and the next one's pnea is a breathing rate. Emia is a blood condition, so relating to the blood. Oxia is oxygen, related to oxygen levels in the blood. Urea is urination. And then lithiasis is stones, so like kidney stones or gallstones. There are specific terms we will use that are more medical, and they all include the term lithiasis for those stones. Okay, like I said, a good number of prefixes and suffixes, but will really help you in the long run. Let's do some checks for understandings. Based on the common prefixes and suffixes, what do you think the term polyuria means? Yeah, so poly means many. Urea means urination. So polyuria would mean many urination. Well, that's a silly way to say that. We would say excessive urination, making too much urine. Okay, next ones. Here we have 4 different terms: hypertrophy, atrophy, dysplasia, and hepatitis. Using those common prefixes and suffixes, what do you think each of these terms means? Okay, let's check your work. So this first one, we have a decrease in cell size. So you would want to think decrease or not or without. That's of those options, A would be the best choice. So this must be atrophy. Increase. So what is that term that means increase? That would be hyper. So hypertrophy would be the best choice here. Deranged or like difficult or bad. So that would be dys. So this would be dysplasia. And then inflammation of the liver. What's the term that means liver? That's hepata. So that would be hepatitis. So once again, you might notice, well, like, oh, but there's like multiple things that could be more or increase. How did I know it was hyper? Well, in that case, I only gave you 4 choices, right? So of those 4 choices, hypertrophy would be the best choice. And that's going to be true on the midterm and on the final too, right? Everything is multiple choice. That's another reason to learn these prefixes and suffixes, because you can use that to logic your way through that answer, especially if you're given choices. Okay. So that sets some foundations just to give us a little vocab to get started. And so that with that, we are going to go ahead and start on the first chapter for Module 1, which is Chapter 2, all about cellular injury and adaptations. Okay. So in this chapter, we learn this really important concept that you're going to use throughout pathophysiology, and that's this idea of etiology. So etiology is the original cause of the problem we're talking about in cells or the disease. So it's like the causative agent. It's important to understand the etiology because cells will do specific things. They have specific patterns and changes they will make in responses to specific types of changes, so specific etiologies. In general, there's essentially two possible responses a cell will make to some sort of causative agent. The first is the cell will adapt and compensate. The second is the cell will try to adapt but end up doing something bad. So essentially the cell will try to deal with it and it can handle it, or the cell will try to deal with it and actually cause another problem in doing so. So thinking about those different etiological agents, there's a lot of different types of agents that can cause different types of cellular injury. This is a nice schematic that kind of summarizes a lot of these things. So for example, the cell, when it becomes injured, depending on how severe that injury is, it might be a reversible injury or an irreversible injury. If it is a reversible injury, that cell can adapt to the stress potentially and then continue to be a normal cell. So that would be an example of sort of like a normal adaptation. If that injury is severe, we would consider it to be an irreversible injury. In that case, the cell is going to die. And there are essentially two types of cell death, two ways that a cell can die. There's apoptosis, which is healthy cell death. So this would be a normal, healthy adaptation. And then there's necrosis, which is bad cell death. So this would be considered a maladaptive process. And we're going to talk a little bit more about both apoptosis and necrosis in a second. Okay, so I mentioned there's a lot of different causes of cell injury. Your textbook goes through a lot of different, or a lot of these in more depth. We are just going to focus together on a few of these causes, and that's because these are the ones that are going to pop up most frequently throughout patho. So the first is hypoxia. So remember, hypo means low and oxia means oxygen. So hypoxia is low oxygen. In other words, this is oxygen deprivation. Your cells need oxygen. Maybe you remember from biology, I hope you do, that cells need oxygen in order to power aerobic cellular respiration and make ATP. And so if there's no oxygen or low oxygen, that aerobic cellular respiration is going to stop. And then essentially ATP production is going to stop. Cells need ATP to survive, so the cell is going to totally stop working. And then because of that, there's all of these issues that will happen to the cell. You'll see swelling, you'll see buildup of different electrolytes, which will cause damage to the cell. And then the cell can also switch to the other type of respiration, anaerobic respiration, to make a little bit of ATP in the short term, but that makes a byproduct called lactic acid, at least in human cells. And that is acidic. So if that lactic acid, if there's a lot of it, that can also damage the cell. So essentially, hypoxia causes cell dysfunction and cellular damage. So how does hypoxia, what causes hypoxia, I should say? So there's essentially two causes of hypoxia. The first is ischemia, which is a vocab term you absolutely should memorize. So ischemia is decreased blood flow. So that could be due to like a clot. It could be due to maybe like compression that's like limiting blood flow, something like that. Either way, ischemia means decreased blood flow. Blood is how oxygen is delivered to tissues. So if you decrease blood flow, that's going to cause hypoxia. And then hypoxia can also be caused by anemia. And anemia is when you have a decrease in the number of red blood cells, or maybe the red blood cells are defective, so they don't have the normal amount of hemoglobin, or the hemoglobin itself is defective, so they're not carrying oxygen the way that they normally should. Either way, the result is going to be the same. You have decreased delivery of oxygen to tissues, which is what causes hypoxia. So once again, no oxygen means those cells are going to switch to anaerobic cellular respiration. So they have inadequate production of ATP, and then they start to make lactic acid, that byproduct, which builds up in the cells and causes damage. So that is why hypoxia is causes cellular injury. So this is a very important cause of cellular injury to memorize, and you should also memorize both of these terms as well. Ischemia, decreased blood flow, and then anemia, essentially like a lack of oxygen delivery due to issues in red blood cells. Okay, so check for understanding, same thing, pause and then check your answer. What is hypoxia? Okay, so once again, hypo means less or lower. Oxia means oxygen, so hypoxia is low oxygen or decreased oxygen levels, to put it a little bit more scientifically. Okay, So second cause of cellular injury that we are going to go over are something called free radicals. These are also called reactive oxygen species. So you might remember from chemistry that when you have two atoms sharing electrons, that makes a covalent bond. And that's because atoms like to have full valence shells, right? So turns out that electrons are very reactive molecules, and they like to exist in pairs, like in a shared pair of electrons in a covalent bond. So if you have a molecule that has an unpaired electron, that is actually a very reactive molecule. That molecule is going to go around trying to give that electron to whoever it can. And the result is that it's going to glob on to other molecules and cause damage. So that is essentially what a free radical is, or a reactive oxygen species. It is a molecule that contains oxygen that has an unpaired electron, and then that electron is just very reactive and can glob onto molecules and cause all sorts of problems throughout the cell. So for example, the specific types of problems that free radicals and these reactive oxygen species can cause is they tend to especially bind to lipids within the cell membrane. And when that happens, it actually causes those molecules to interact with each other in a different way that makes the cell membrane less good at being a barrier. So it's going to cause the cell membrane to kind of fall apart and degrade. And obviously that's bad because now toxins are coming in that shouldn't be, the cell's extra permeable, it's losing stuff it shouldn't, so that cell is going to die. When that happens, when we have these free radicals and these reactive oxygen species reacting with and damaging cells, we call that oxidative stress. It's a specific type of cellular injury. Okay, check for understanding. This one's from 2 slides ago. What are 2 causes of hypoxia? Okay, so remember hypoxia is low oxygen. We talked about 2 causes. The first is ischemia, which is decreased blood flow to the tissues. And the second is anemia, which is reduced ability for the blood to carry oxygen because of issues in red blood cells or because of issues with hemoglobin itself. Okay, so those are really the only 2 causative agents we're going to talk about in depth. So hypoxia, decreased oxygen, and then those free radicals causing reactive oxygen species and oxidative stress. Like I said, there are other causes of cell injury that are covered in your textbook, but we're only going over those 2 because those are the ones that you're going to see most frequently throughout the rest of the course. So with that, we are going to move on to thinking after that cell has undergone some sort of stress or some sort of injury, not necessarily always hypoxia, those are just the only 2 we went through. But after a cell has gone through some sort of injury, what are the kinds of adaptations that that cell can undergo? So the first type of adaptation could be a change in the size of the cell itself. So there's essentially 2 ways that a cell can change its size. So this is our normal cell. Something called hypertrophy. This is when that one single cell becomes larger. So remember, hyper means more, trophy or trophic means grow. So it's growing larger, more growth. So notice here, there's not more cells. It's still one cell, but that cell has just become bigger. The flip side is called atrophy. So in atrophy, the cell has shrunk and become smaller. So why would this happen? What is the sort of etiological agent that's causing these types of changes? It's mostly going to be due to changes in metabolic demand, meaning changes in how much energy the cell needs to use. So if there's increased metabolic demand, meaning the cell is having to use more and more and more energy, then you'll have hypertrophy. The cell will grow larger. Hypertrophy can be physiological, meaning normal and healthy, or pathological, meaning a bad maladaptive change. For example, if you go to the gym and you're working out really hard and trying to build your muscles and make them bigger, if your muscles do get bigger, that is hypertrophy. And that is usually physiological hypertrophy because it's happening slowly over weeks and months. So your cells have plenty of time to grow a little bit bigger and make sure they're getting adequate blood flow and really adequately respond to that stress. Pathological hypertrophy would be, this happens, for example, in the heart. Sometimes if the heart is having to beat faster or beat harder than it normally would, sometimes it will become hypertrophic and those cells will become bigger, but they have to do so really fast and they do so in a way where they're not getting adequate blood flow and nutrition. So in that case, the tissue kind of tends to be like disorganized and doesn't work quite as normally. So that's hypertrophy. And then atrophy, that would be due to less metabolic demand. So for example, using your muscles again, you go to the gym, you work out really hard, your muscles get big, that's hypertrophy. And then you go to nursing school and you don't have time to go to the gym anymore. So you stop going and then your muscles get smaller, and that's atrophy. Okay. So the next vocab term, this one is about changes in cell number, so not cell size. So hyperplasia, so hyper once again means more. Hyperplasia is an increase in the number of cells. Usually this is due to increased progression through the cell cycle, so the cell is just dividing more rapidly. And this can be, once again, adaptive or maladaptive, so it can be a good thing or it can be a bad thing. So for example, an example of a maladaptive or a bad example of hyperplasia is a keloid. So a keloid is a sort of like big raised scar that appears after a wound has healed. During wound healing, you need those cells to divide and fill in that gap. That would be adaptive, that's normal. But then if those cells keep dividing and they don't stop, once the wound is healed and they keep growing, then you'll get this raised scar, which is called a keloid. Keloids themselves aren't necessarily like harmful or dangerous. They can maybe reduce some range of motion. I have a keloid on my ankle because I ruptured my Achilles tendon and had surgery for that a few years ago, and it does limit my range of motion a little bit, but it doesn't like hurt me or anything. So it's not that these examples are all causing like harm to health or are dangerous, just these are all just examples of different types of cellular adaptations. So a keloid is just a maladaptive change. It doesn't mean that it's causing like a disease or a disorder necessarily. Okay, so the next vocab term is metaplasia. So this is an example that is a change in the type of cell. So this would be a replacement of one type of cell with another. This is usually in response to repeated stressors on that cell. So for example, let me go back a step. A good way to remember what metaplasia is, you can think it's metaplasia like metamorphosis. In metamorphosis, a caterpillar changes into something else. It changes into a butterfly. In metaplasia, one type of cell metamorphosizes. It changes into a different type of cell. So an example of metaplasia might be in someone who is smoking. There is a common type of metaplasia that happens where cells in the throat, which are normally these types of cells called squamous epithelial cells, will change to a different type of epithelial cell called columnar epithelial cells. And that is essentially because they're changing to a type of cell that's a little hardier and able to withstand more toxins, like the toxins in cigarette smoke. So the cell is trying to protect itself. But the problem is when cells are doing this, if they're changing into a different cell type, it's possible during that change that the cell might develop some mutations or maybe kind of take off some of the regulations that prevent it from growing and dividing out of control. So it turns out that any sort of metaplasia predisposes that cell to becoming cancerous. So even though this is an adaptation that's trying to help the cell, in the long run, it could be harmful to the patient because it does increase the risk of those cells becoming cancerous in the future. Another example of metaplasia, this one is going to come up a couple times throughout the course, is GERD, which stands for gastroesophageal reflux disease. So this is when people have acid reflux, or in other words, heartburn, so acid coming up from the stomach and going into the esophagus. So stomach acid is always in the stomach, right? So the cells in the stomach are constantly exposed to that stomach acid and they're protected from it. So stomach cells are a little bit hardier. They make this mucus that protects them from the acid, so they don't mind acid. Esophagus cells are not normally exposed to acid. If you have ever had heartburn, you have felt that firsthand. Heartburn hurts. It hurts because that acid is literally burning those cells in your esophagus that are not used to it. So what will happen in someone who has recurrent acid reflux, where this keeps happening, is some of those epithelial cells, which are, once again, not used to acid and getting damaged by it, will undergo metaplasia and become stomach-like cells. Because remember, the stomach cells don't care about the acid. So the cells are trying to protect themselves and adapt to this adaptation. But once again, in doing so, the cell has now kind of taken off some of the regulations that control the cell cycle. So these cells are more likely to become cancerous in the future. So this is a specific finding called Barrett's esophagus when this happens. And a person who has Barrett's esophagus is just at higher risk of developing esophageal cancer. And if that were to happen, oh no, I skipped one, just kidding. The next one, changes in cell morphology. So remember, dys means bad. So dysplasia, these are cells that are bad or abnormal in their size or shape or appearance. Dysplasia can also be a precursor to cancer. So the first one we talked about that's a precursor to cancer, metaplasia. One cell is switching to a different type of cell. Dysplasia, the cell is still the same type of cell, but it just like looks kind of wonky. It doesn't look how it normally should. But both of those are precursors to potentially becoming a cancerous cell. Classic example here is cervical dysplasia. If you've ever had a pap smear, this is essentially what that test is looking for. It is looking for these bad or abnormally shaped cervical cells. And that is because if you see some of those abnormally shaped cervical cells, it indicates that you might be at higher risk of cervical cancer. Okay, and then that takes me to the last one, which is neoplasia. So both metaplasia and dysplasia predispose those cells to becoming cancerous. If that happens, we would call those cells neoplasic or neoplasia. So this is disorganized, uncontrolled cell growth. This is just another term for cancer. Neoplasia can be benign or malignant. So malignant means that they're really poorly differentiated, meaning they just don't look like the original cell they were at all. You just know that they, like for example, originally were a skin cell because they are on your skin. Neoplasia, I want to emphasize this, is different than hyperplasia. So hyperplasia is too many cells, but the cells themselves are still like normal cells. There's just a lot of them. Neoplasia, they're too many cells, but they are like the cells themselves are abnormal, so they're poorly differentiated. They don't have like nice defined borders. They're kind of spreading all over the body. So this is something that we would be considered cancer. Whereas hyperplasia, like for example, a keloid, that's not cancer. That's just a scar. And it may or may not be kind of uncomfortable, but it's not cancer. Another thing to notice is that neoplasia is usually irreversible, meaning that change is never going to go backwards and become a not cancerous cell. Whereas it is possible if you have hyperplasia that your body can reduce some of those cells and it would kind of like resolve on its own. Okay. So those are all different vocab terms for different types of cellular adaptations. Once again, the understanding these types of cellular adaptations is important because this is sort of the foundation for understanding different diseases and disorders. So let's do a check for understanding. Uh-oh, I gave you the answer already, but go ahead and pause and think if you can think, what is the term that means replacement of one cell type with another? Yeah, how did you figure it out? Yeah, so that's metaplasia. So remember, meta, like metamorphosis, the cell is changing type. Okay, how about this one? What is the difference between hypertrophy and hyperplasia? Yeah, so hyper means more or greater. So we know that both of these have something to do with more or greater, but the difference is in that end part. So trophic means growth. So hypertrophy, the cell is growing larger. It's getting bigger just in size. Like the size of the cell itself has gotten larger. Hyperplasia is more cells. So increased number of cells, increased cell division. Okay. And then that is going to take us to the two different types of cell death. Remember, I said there is apoptosis, which is like the normal healthy cell death, and then necrosis, which is the sort of bad cell death. To help you understand these two different processes, we're going to watch these videos. Both of these videos are microscope videos of real cells undergoing this process. So let's start with this one of apoptosis. Turn off the sound. Sorry, let me pause so we can get ourselves oriented here. So this is the cell. The blue stuff here is that cell's membrane. And then this like reddy yellow stuff in the middle, that's essentially the nucleus. So what you can see is the cell's membrane, its little like feet are starting to pull in. So the cell's kind of like condensing itself and getting smaller. And as we watch, here we go. And now the cell is starting to kind of like compartmentalize itself, and it's going to kind of smoosh itself into little packages. Any second now, there we go. Okay, so it's becoming like these little blebs. See, there goes a little bleb. And it's kind of like packaging itself up really, really tiny. And the reason the cell does that is because in apoptosis, that cell is essentially going to condense itself really small, and then its membrane is going to condense itself even smaller into some little tiny vesicles. And then the cells nearby can actually absorb those vesicles and essentially like recycle that cell. So it's very neat. It's very tidy. It's like if you're moving houses, you condense all your stuff, you put it in boxes, and then you take it to the next house. Like it's very neat and tidy. So I hope you can recognize how that's going to be different than the next type of cell death, which is necrosis. So let's watch this one. So this video is not fancy color, but it's still one single cell. So here's the cell right here, and then this is its nucleus right there. So this one's going to go faster. We see our cell, it's just kind of sitting there. It seems to be just vibing. And then all of a sudden, as we watch, oh my God, where'd it go? It just disappeared. So essentially, when that happened, what happens is that cell just exploded. It just exploded. So to use the analogy of a house, once again, apoptosis is like you're moving to a different house. You got to pack up all your stuff and you're moving. Necrosis is like your house explodes. So now you need to go buy a new house. All your stuff is gone. It exploded. So necrosis is bad. There is never a healthy or a good example of necrosis. It is always pathological. And in addition, because that cell essentially exploded, let's say that like a virus is what caused that cell to explode. Now that virus is also going to be everywhere and it will be able to infect other cells. So necrosis tends to injure the cells nearby as well. So it's a harmful process. I should mention, sorry, that apoptosis is a normal healthy process, meaning it's a normal part of your body. But if you have too much apoptosis, that can be a bad thing. So for example, hair loss, like male pattern baldness, that is caused by, in part, an excess of apoptosis. Just the cells are a little too sensitive and they undergo apoptosis too much. Okay, so those are our two types of cell death, apoptosis and necrosis. So like I said, necrosis is the bad one, the pathological one. So it's always going to be associated with some sort of disease or disorder. So some examples that are clinically relevant of necrosis. The first is gangrene. So this is necrosis, once again, that bad exploding cell death that is due to lack of oxygen. And then that lack of oxygen is usually due to an infection. So this would be hypoxia causing some cellular damage, which then causes necrosis. And this, once again, specifically happens after an infection. This tissue that has undergone gangrene is going to look like black. We actually would say that this looks necrotic and like crusty. It might smell. So these are all different indicators of necrotic tissue. Another example, which you should definitely know, because this is going to come up multiple times throughout the term, is an infarction. So this is necrosis that is due to lack of oxygen due to a blood clot. So in other words, this is necrosis in response to prolonged ischemia. Ischemia is that lack of oxygen due to like a clot or occluding a blood flow. Lots of different examples of infarction. Most common one is a myocardial infarction, commonly known as a heart attack. So this would be lack of blood flow to the heart muscle, causes ischemia and prolonged hypoxia. That makes that tissue die, necrotic cell death, and then that causes a heart attack. So it's permanently damaging the heart tissue. Okay. Check for understanding. What type of cell death is involved in normal healthy processes such as wound healing? Yes, so that would be apoptosis. Apoptosis is the healthy cell death. Necrosis is the bad one. So even if we're talking about like a wound, which was an injury, during that wound healing, some apoptosis will be involved. That would be an example of healthy cell death because it's doing what it's supposed to do. Okay. Myocardial infarction, more commonly called a heart attack, is when prolonged blank leads to blank, death of cardiac cells. Yeah. So for this one, remember, this is a heart attack. It's a bad thing. So we're talking about the bad type of cell death here. So we're definitely talking about necrosis. So our two options would be A, normoxia, or C, ischemia. Well, normoxia, that sounds like normal oxygen. Ischemia, that's lack of blood flow. So which one is more likely to cause damage and to cause necrosis? Well, that would be ischemia. So once again, ischemia, that causes necrotic cell death. That is the definition of infarction, a very important vocab term for you to know. Okay, so with our first chapter for Module 1, let's go ahead and move on to the next chapter, which is Chapter 3, Genetic Diseases. This chapter has so much information in it, but you only need to know 4 diseases and disorders. So it's really important when you are reading through the chapters that you're looking at the read section in Canvas and only reading the sections that you're responsible for. This chapter is a really good example where you're only responsible for like 10% of the chapter. So don't read the whole thing. That's just making more work for yourself. Okay, so what is a genetic disorder? So a genetic disorder is one that is caused by abnormalities in DNA. And specifically, these are abnormalities that have to be inherited. So meaning they are passed from parents to children. Another way we might say this is someone with a genetic disorder is, quote, born with that disorder. They don't catch it from someone else, and it's not caused by lifestyle factors. So some examples of different genetic disorders. These are all examples that I think most of these are in your textbook, but once again, you don't need to know them for this class. But some examples would be something like Fragile X syndrome, because that is caused by a chromosomal abnormality that someone is born with. That is different than other diseases and disorders that still have something to do with the DNA, but they are not inherited disorders. So cancer would be an example of this type of a disorder. So cancer is caused by an accumulation of mutations in DNA, but these mutations are not passed on. Like you're not usually born with cancer. Cancer is something that is usually caused by lifestyle factors, like you're exposed to radiation or you're exposed to cigarette smoke. It's also just caused by age. So this is not an example of a genetic disorder, even though it has a DNA component. So once again, all of the disorders in this chapter that we're talking about are all things that someone is, quote, born with. They don't catch it or something like that. Okay, so in general, there are 2 main categories of genetic disorders. There are single gene mutations, so where there is a mutation in one single gene that causes the genetic disorder. And then there are chromosomal abnormalities, meaning a change in the number or like the appearance of chromosomes. For single gene mutations, there are 2 subcategories depending on where that gene is. If the gene is on an autosome, meaning all of the chromosomes that are not sex chromosomes, then we could say that that single gene disorder is either autosomal dominant if the mutation causes the disease, or autosomal recessive if the mutation will cause the disease only if you get 2 mutated copies of the mutated gene. If the gene that causes the genetic disorder is on a sex chromosome, then that could cause something like an X-linked recessive genetic disorder. So this would be the mutated gene is on an X chromosome. And then once again, for chromosomal abnormalities, these are genetic disorders where the issue is with the number or the appearance of chromosomes. There are 2 categories. Aneuploidy is a change in the number of chromosomes. Trisomy, for example, would be having 3 copies of a chromosome instead of the normal 2, whereas monosomy would be 1 copy of a chromosome instead of the normal 2. And then you can also have genetic disorders that are caused by partial chromosome deletions. So like a chunk of a chromosome is missing, or maybe it's been moved onto a chromosome that it should normally be found on. Okay, so just a nice little review of different types of genetic disorders. For this course, for patho, you need to know 4 genetic disorders. You need to know cystic fibrosis, which is an example of an autosomal recessive disorder. You need to know Tay-Sachs disease, which is also an autosomal recessive disorder. You need to know Huntington's disease, which is autosomal dominant. And then you also need to know Down syndrome, which is an example of a chromosomal abnormality. Specifically, it is trisomy 21. So we're going to go over each of those just briefly, because I know you've probably learned about these in other courses. Okay, so the first genetic disorder you need to know is cystic fibrosis. Once again, this is an autosomal recessive genetic disease, meaning someone who has this disease is born with it. It is autosomal, meaning the mutation is in a gene that is not a sex chromosome. And recessive, meaning someone who has cystic fibrosis has to have 2 copies of the mutated gene, meaning they got one from their mom and one from their dad, in order to have the disease. So what causes cystic fibrosis is a mutation in a specific gene called CFTR. It's the cystic fibrosis trans receptor, something like that. And so what this mutation does is the normal gene makes a protein channel. So this is a cell, and this is the cell membrane. And remember, within the cell membrane, you have these protein channels that allow certain molecules to pass the cell membrane. In this case, this channel is a chloride channel, so it lets chloride ions go across the cell membrane. Also remember that you learned in biology that salt sucks, meaning that as molecules cross the cell membrane, they are going to bring water with them. So if you have lots and lots of chloride ions outside the cell membrane, you're going to have lots and lots of water. Well, it turns out in the mutation that causes cystic fibrosis, essentially these chloride channels stop working. So when that happens, instead of these chloride ions being able to leave, they all get stuck inside the cell. Well, if those chloride ions are stuck in the cell, that means water is going to stay inside of the cell too. So you're not going to have water outside the cell. And the consequence of that is if there's mucus outside of that cell, that mucus is going to be way thicker than it normally is because it's going to have less water in it. So essentially what happens in cystic fibrosis is you have this buildup of like thick, sticky mucus. So any organ that has a mucus lining is prone to being affected by cystic fibrosis. The 2 organs that we classically think of as being affected are the lungs. So it causes respiratory issues breathing, and then also the pancreas. So you can have issues making like digestive enzymes, for example. The respiratory issues are ones that are really concerning because if you can't get adequate oxygen, then that's going to affect your whole body. So a lot of the treatments for cystic fibrosis are aimed at opening the airways. So this could be through bronchodilators, like an asthma inhaler almost, or steroids. Those are both things that are going to reduce inflammation within the lungs and just help make breathing a little bit easier. There's also things like PT specifically for the chest, or even there's like these like vests people can wear that kind of like beat on their chest and help break the mucus free. Those are some of the examples of medications and treatments for cystic fibrosis. There's a lot more than just that, but those are some examples that you should know for the midterm. Okay, the next genetic disease you need to know is Tay-Sachs disease. Tay-Sachs is also an autosomal recessive disease, meaning the only way that someone can have that disease is if they get the mutated disease allele from both parents. So Tay-Sachs, what happens is in that mutated allele, it causes an issue in the lysosomes within cells. So the lysosomes essentially stop working. And lysosomes, remember, are like the recycling bin of the cell. They break down waste. So if you don't have the recycling bins, if you don't have a way to break down waste, then waste is going to accumulate in the cell, and that's going to cause damage to the cell. Turns out that the brain is especially susceptible to this type of damage. So you get this accumulation of a specific toxin called a ganglioside in cells, specifically in cells within the brain. So because the toxins have to accumulate to have problems, what will happen is someone who is born with Tay-Sachs disease won't at birth have any symptoms, but as they get older, they will have progressive deterioration in brain function. So essentially, as they get older, more and more of those toxins are building up, and that's going to cause progressive damage to the brain and deterioration over time. There's unfortunately no treatment for Tay-Sachs disease. It is usually fatal by age 3. So the best treatment, quote, treatment in this case is prevention. So generally, if you know that Tay-Sachs runs in your family, or there's specific ethnic populations where Tay-Sachs is more common, such as Ashkenazi Jewish populations, then you might get screened for Tay-Sachs, like you might undergo genetic testing, and your partner would as well. And if it turns out you're both carriers for Tay-Sachs, meaning that you have one copy of the gene disease or the mutated allele that can cause the disease, If you're both carriers, then there's a 25% chance you could have a child with that disease. So in that case, the couple might opt to do something like IVF and then screen their embryos to make sure that that they're not implanting embryos that would cause the disease. Because once again, the people usually die by age 3. So it's really sad. Okay, so that takes us to the next genetic disorder, which is called Huntington's disease. So Huntington's is an autosomal dominant disease. So it's dominant, and that means you only need one copy of the disease allele in order to have this disease. It's also very, very rare. This gets to a common misconception that students often have about genetic diseases, that one, they're always recessive, and that recessive things are always rare. That's not necessarily the case. Huntington's disease is very rare, but it is dominant, meaning if you get even just one copy of that gene, you will get it. The sad thing about Huntington's disease is it doesn't usually show up, or you don't usually have any signs or symptoms until you're like mid-aged, so like 30s or 40s. So that means you might have already had kids before you knew you had the disease, which is really sad. So what happens in Huntington's disease is there's a issue in specific cells within the brain, specifically in a place called the basal ganglia. And essentially within the basal ganglia, so that's like this region right here, in someone with Huntington's disease, you will have degeneration. So see how there's a hole this big, and then this one, the hole's gotten bigger. It's because this part of the brain that was right there has essentially gone away, has or not even atrophied, has died. So you have neurodegeneration, loss of brain tissue over time. So that's going to cause progressive, meaning gets worse with time. Motor dysfunction, so inability to control your movements. And then with later stage, you also have behavioral changes. The classic symptom, or the classic sign, I should say, of Huntington's disease is chorea, which are dance-like movements. We are going to watch just a small portion of this video of someone who has Huntington's disease, where she's talking about her experience as someone who lives with Huntington's.
Good. And right now, I'm just coming out of a dystonic storm. Well, I'm almost out of it. I just want people that don't know what they look like to know what they look like.
Okay, so you can see there that she's obviously having trouble controlling her movements. So that's what we mean by motor dysfunction. And the fact that it's kind of like this shaky, jerky movement as opposed to just like a tremor is why it's called chorea, sort of like a dance, like a bigger movement. So that is the third genetic disease that you need to know, Huntington's disease. And then the last genetic disease that you need to know is Down syndrome, also known as trisomy 21. So this is caused by either an extra copy of chromosome 21, so instead of 2 copies, there are 3, or there are also types of Down syndrome that are caused by maybe not an entire third copy of chromosome 21, but maybe just an extra piece of chromosome 21. So not the whole thing, but maybe just a chunk of an extra chromosome 21. So Down syndrome would have to be diagnosed by a type of laboratory test called a karyotype. That is essentially what this picture is showing. So a karyotype is you take some cells and you take a picture of all the DNA inside of one single cell, and then you use like Photoshop to arrange that DNA into this nice, neat little picture that shows you like, oh, they have 2 copies of chromosome 1 being defined as the longest chromosome, 2 of chromosome 2, 2 of chromosome 3, et cetera, et cetera. That's what you should have, 2 of each one. And then if you see 3 of chromosome 21, now that would be trisomy 21, which once again is Down syndrome. There are some classic signs and symptoms associated with Down syndrome, some characteristic facial features, hypotonia, so decreased muscle tone, a single palmar crease, which is once again a facial feature. About 80% of patients with Down syndrome have a reduced IQ. And patients with Down syndrome also have an increase of developing specific types of leukemia. Okay, and those are the 4 genetic disorders you need to know. Once again, there were lots of other genetic disorders in that chapter. You only need to know those 4. Okay, so let's move on to the next chapter. in this module, which is Chapter 9, Inflammation. So inflammation, I feel like in everyday terms, gets kind of a bad rap. It just feels like it's something that people are like, oh, you have inflammation. It sounds like it's a bad thing. And too much of a good thing can be bad for sure. If you have chronic too much inflammation, that is bad. But often the inflammatory response is a adaptive, helpful response that is trying to fight infection. Just there are kind of uncomfortable side effects of that response. And once again, if that inflammation goes on too long, that is what can cause problems. So the point of inflammation, the reason that it is helpful in fighting infections is because it is trying to essentially isolate the tissue that is being injured. The point of that isolation is to prevent whatever is causing that injury. So like bacteria, for example, from spreading to other parts to the body. So if you isolate that injury, it's going to keep those bacteria in one place. And then the other point of inflammation is to help cells from the immune system get into that site of injury so that they can fight the infection and promote healing. So we're going to watch just a quick clip from this video where he goes through some of the steps of inflammation. I think it's just a nice animation.
The purpose of the inflammatory response is threefold. First, it allows the body to defend itself from invading microorganisms. The increase in vascular diameter, along with the activated endothelial cells, results in leukocytes being able to attach to the endothelium, and then migrate into the tissues where they can attack pathogens. This process of leukocytes leaving the bloodstream and entering tissues is called extravasation. Second, it induces local blood clotting, and this creates a physical barrier which prevents the infection from spreading into the bloodstream. Third, it promotes the repair of injured tissue.
Okay, so like I said, we didn't watch that whole video, just a quick little overview. So let me get this big again. I like that because it just kind of gives you a visual of what is happening in these different steps of inflammation. And we're just going to go through these steps in a little bit more detail.
The purpose.
Okay, so the phases of acute inflammation, acute once again, meaning sudden onset, this would be like directly after an injury. There's essentially three phases. So the first is increasing vascular permeability, meaning letting the blood vessels become a little bit more leaky. That's to help those white blood cells get to the site of injury. The second is cellular chemotaxis. That is those white blood cells and those immune cells actually moving to the site of injury. And then the third is systemic response. So this would be things like fever, pain. This is essentially helping trying to fight that infection and also heal that wound. So fever, that is something that can help fight infection. Something like pain, that's going to get you to stop using that injured area so that it has a chance to heal and doesn't get like further damage. Okay, so these three phases cause essentially 5 classic signs of acute inflammation. So these 5 classic signs are pretty much all due to that increased vascular permeability. So once again, the blood vessels become a little bit leaky, and that's on purpose because that's helping get those immune cells, those white blood cells, to the site of injury. But because the blood vessels are leaky, we're going to see some classic signs. So the 5 classic signs are pain. Once again, the pain is more to stop you from using that area and damaging it more. All these other things are really due to the leakiness. Warmth, so the area will feel warm. Redness, swelling, and then loss of function. The damaged area is just not going to work as well as it normally does. A trick you can use to help you remember the 5 classic signs of inflammation is sulfur, SLPHR. So it's like sulfur without any of the vowels in it. To me, sulfur, I think of like demons, because supposedly demons smell like sulfur or something. Maybe that's just because I watched a lot of Supernatural, but it makes sense in my brain. So remember sulfur, so swelling, loss of function, pain, heat, redness, like a demon, sulfur. Okay, so like I said, that increased vascular permeability is by design. It helps, it makes the leakiness, which helps those immune cells get to the site of injury. Some of the things that also happen because of that increased vascular permeability is fluid is going to leave the blood vessels. So if it is fluid and also cells, that fluid that's full of white blood cells, we would call that pus or purulent exudate. So once again, it's just fluid that is filled with those white blood cells. So if you've ever had a pimple, which I don't know who hasn't, and it has a white head, that is an example of pus. Once again, it is fluidy, it's liquidy, because it is purulent exudate. It is this fluid that is full of white blood cells. That's a little bit different than another type of fluid, which we call transudate. This is a watery fluid that doesn't have any blood cells in it. So for example, if you have had a blister and that blister has some fluid itself in it, but it's not pus, it's not like white fluid, it's kind of a clear fluid, that's called transudate. Still caused by the same thing though, that increased vascular permeability. Just in this case, the permeability is a little bit less, so you don't also have white blood cells leaving, you just have fluid. Another example of a transudate would be effusion. So this is accumulation, once again, of just fluid in a body cavity. For example, we will learn in a few weeks about a pleural effusion, which is an accumulation of fluid within the lungs. You could also call this like water on the lungs. So that's going to cause difficulty breathing. And so the whole point of these leaky blood vessels is to get enough space for those white blood cells to be able to leave the blood and then fight the potential infection at that site of injury. That movement of white blood cells, that is called chemotaxis. Specifically, there are signals that attract those white blood cells to the site of injury and that cause chemotaxis. I always remember taxis. It looks like it has the word taxi in it. So that helps you remember like, oh, the cells are catching a taxi. The cells are moving. If we are talking specifically about just white blood cells, there is a vocab term that we'll talk more about next week that has to do with increased amount of white blood cells, which is called leukocytosis. This is more white blood cells in the blood. This is often due to an infection because those white blood cells need to get to the site of injury. So we're going to need more of them in order to prepare to fight that infection. So seeing an elevated white blood cell count is often a sign of an active inflammation and like an active infection. And we would specifically call that elevated white blood cell count leukocytosis. That is like the specific medical terminology for that. Okay. And we'll go over a little bit more of this next week, but just a little review from A&P since we're on the topic of white blood cells, of different types of white blood cells. There's a lot of information here and you don't need to necessarily know all of it. For patho, I would say the level that you should know is this level right here. So just being familiar with these different terms and knowing that they're different types of white blood cells for this week at least is a good idea. So we have neutrophils, eosinophils, and basophils. These are all different types of granulocytes, which are a type of white blood cells. And then we have lymphocytes and monocytes. These, once again, are another type of white blood cell which belong to a category called agranulocytes. This section up here, knowing that difference, it's not so important. Like I said, for this week and for next week, at the very least, you should know that these are examples of types of white blood cells. Okay. So what happens when we're talking about these types of white blood cells as they're responding to an infection and as they're essentially undergoing this acute inflammatory process? So thinking about these different types of white blood cells, the first white blood cell on the scene are called neutrophils. They are the most prevalent in early infection. Neutrophils, their normal function is phagocytosis, which is essentially eating stuff. So let's say you have like a bacterial infection, neutrophils can come in and eat those bacteria to kill them. So they're first on the job. The next sort of wave of cells are monocytes, and they change into a different cell type called macrophages. They also do phagocytosis. So first on the job, we have the two phagocytotic cell types. We have neutrophils and then macrophages, which are derived from monocytes. The nice thing about macrophages is they stick around longer than the neutrophils. And then you have another type of cell. This is another example of a type of white blood cell called mast cells, and they produce something called histamine. Histamine is important for just increasing vascular permeability. And then you have another type of white blood cell called lymphocytes. Those help to produce antibodies. So this happens usually much like days to weeks later after that time of injury. So really it's these neutrophils and the macrophages that are going to fight the injury in the short term, and then lymphocytes are going to come on a couple days later. So they're sort of the later response. But lymphocytes, since they are producing antibodies, they're the ones who will remember that pathogen and prevent you from getting infected again. Next week in Module 2, we're going to talk more about white blood cells and the immune system. So we'll revisit a lot of this. This is just sort of a very brief, quick little reminder of some of these things about white blood cells because it's relevant to talking about the inflammatory process. So if you feel like, I don't remember a lot of this, for this week, it's okay. Don't worry about it too much, but definitely maybe review a little bit about white blood cells before Module 2. Okay, and then I wanted to just really quickly talk about this guy, the mast cell that produces histamine, because histamine is something that can cause some diseases and disorders on its own. So for example, allergies. Allergies are essentially caused by inappropriate release of histamine. So histamine is something that is released from mast cells as part of the inflammatory response. They're involved in that increased vascular permeability, so they cause vasodilation. Because of that, histamine essentially causes all of the symptoms that you associate with allergies. So like a runny nose, hives, itchiness, all of those things are caused by histamines. And that is why you treat allergic reactions with antihistamines. So in terms of what you should know for the midterm, you should definitely know that histamine is one of these molecules that's involved in the inflammatory response. And you should know that histamine is released from mast cells, which are a type of white blood cell. Okay, we're almost done, guys. We're on the home stretch. We're finishing up with chapter 9, which is all about wound healing. Okay, so wound healing, there are 4 phases of wound healing. And essentially, the desired outcome of wound healing is to completely repair, completely join together the injured tissue. So in a perfectly remodeled wound, you won't even be able to tell that anything happened. There are 4 phases of wound healing. The first is hemostasis, which is another word for blood clotting. Before the wound can be healed, you need to stop blood from leaving. That's phase 1. Phase 2 is inflammation. Once again, that's important for fighting any sort of infection, but inflammation is also important because it helps get cells to the wound that are going to be involved in repairing the wound itself. 3, you have proliferation. So cells, once they are getting to that wound, so here are all these cells getting to the wound, they are going to proliferate, meaning they're going to multiply and then fill in that gap. And then the last step is called wound contraction. Contract meaning come together. So that's literally the 2 sides of the wound coming together and healing that wound and making a nice, neat little perfect tissue that you can't even tell anything happened. There is a video on this slide. If you're looking at the slides, we're not going to watch the whole thing together because it's 9 minutes long. This is a really nice overview of the steps of wound healing, and it's got some really nice graphics in it. So I highly recommend, if you are feeling confused on wound healing at all, that you take the time to go to the slides and watch this video. Okay. So let's talk about, so as we talk about the 4 steps of wound healing, there's a vocab term that you should know, which is called granulation. So if you've ever picked a scab and then underneath the scab is that juicy tissue, that's called granulation tissue. So it's essentially the new tissue that is forming. It's not quite all the way normal skin tissue yet, but it's that tissue that is actually starting to heal the wound. So what granulation tissue is it's made by a specific type of cell, which is what's shown in this picture, called fibroblasts. Fibroblasts are one of these cells that go to the site of the wound here. So they're the little blue ones here. And they're going to start to proliferate, and they make this specific protein called collagen, which is part of the extracellular matrix, meaning sort of the scaffolding between cells. And so the fibroblasts come in and they make a lot of collagen, and that's going to sort of make the scaffold that the rest of the cells will fill into. So it's sort of the background to filling in and repairing the rest of that wound. So that granulation tissue is a really important step in wound healing. That's also why they say you shouldn't pick your scabs, because you're exposing the granulation tissue then, and then you can damage it. And that is just more likely to delay or impact the wound healing process. Okay, so like I said, there's those 4 steps of wound healing: hemostasis, meaning blood clotting, inflammation, proliferation, and then wound contraction. Depending on the extent of the damage to the wound, we can use some different vocab terms to talk about that wound. And in that case, you're going to have some changes to the wound healing process, essentially just because if the wound is more severe, the process is going to be a little bit more complicated. So the simplest type of wound is a wound that has primary intention. So this would be where there is no gap in the wounded tissue. So this would be, for example, like a surgical incision. So something where it's very neat, it's very tidy. This is going to be something that should heal essentially with like no scar, and it should be nice and perfect. So it's going to follow those 4 steps really easily, and there's not going to be any challenges. The second sort of severity of a wound is a wound with secondary intention. In this case, there's like a chunk of tissue that's missing. So this is like you fall and you skin your knee and there's a chunk of skin that has been ripped off. It's not clean, it's not tidy. So because of that, the healing process is going to involve a lot of formation of this granulation tissue, and it's going to take a long time to make that granulation tissue because you're really having to fill in that gap. Because of that, these types of wounds are going to be more susceptible to scar formation, for example, like a keloid, because there's just going to be that proliferative process happening for a lot longer. And so there's just a longer period of time for things to kind of go wrong and for more cells to be produced than you necessarily need. And then the most severe and complex type of wound is a wound with tertiary intention. So this is also a gap in the tissue, but usually a much, much larger gap. Because of the size of the gap, the wound itself is going to be contaminated. So in this case, that second step of wound healing, inflammation, the whole point of inflammation is to stop infection. In a wound with tertiary intention, the inflammation will not have been able to stop any sort of infection because the wound is just so big. The inflammatory process had no chance of stopping it. So usually in this case, if this wound is contaminated, a surgeon would not go in and like sew it up because you wouldn't want to sew up a contaminated infected wound because there's infection in here. So instead you would leave the wound open. You might put like a drainage tube in there to just drain some of that purulent exudate, like pus and other fluids out of the wound to try to keep it just as healthy as possible. And then eventually you could finally then, once the infection has cleared, go in and try to repair the wound. Usually these are wounds that are really just like big in area. So often these are wounds that are going to need some sort of skin graft in order to close the wound. The body won't be able to completely heal it by just making lots of granulation tissue like you would with a secondary intention wound. So this would be like a really severe wound, like for example, a burn or like an ulcer, a pressure ulcer. Cool. Check for understanding. So I already gave you the answer. What type of wound is least likely to leave a scar? So that once again would be a wound with primary intention. That is the simplest, least severe type of wound. They are named in order of severity. So primary is the least severe, tertiary is the most severe. Okay, and that takes us to a concept related to wound healing, which is something called eschar tissue. So some wounds can develop something called eschar. So this is different than a scab. This is necrotic tissue that essentially is like formed over the wound. So remember, necrotic tissue is abnormal tissue. It can cause issues with the tissue around it. And so for that reason, eschar is usually going to be removed. The process of removing eschar is called debridement. And the reason you remove it is because it's usually going to help that wound healing process. People who are wounds that are more likely to develop eschar are once again wounds with tertiary intention or wounds that are really big in area. So things like burn, like extensive burns, or really large pressure ulcers. These are things that can cause that eschar tissue. Okay, check for understanding. What is debridement and why is it helpful? Yeah, so debridement is that term for removing that necrotic dead tissue, which is called eschar, which is coating a wound. And you do that because it can help speed up healing of the wound. Okay, so, with that, I lied. I said there's one more chapter, but there's actually a bonus chapter, chapter 10, which is infectious diseases. Don't worry, there's not a lot to cover here. So an infectious disease is one that is caused by a pathogen. A pathogen just meaning something from outside of your body that causes a disease. So it's something that is like an organism, usually that can make you sick. So this would be things like bacteria. So for example, like E. coli or C. diff. Viruses, so COVID-19, influenza. Fungi, candida is really the only infectious fungi. Parasites, that would be like malaria. Protozoa, so there are like some amoebas that can cause like a brain condition where the like amoebas eat your brain. And then infectious proteins such as prions. So these are things that cause like mad cow disease. Super important thing to remember as you're working through this chapter, antibiotics are a class of medications that treat bacterial infections only. So if you ever see a question in a knowledge check or on the midterm talking about like which of these would we use an antibiotic for, what that question is essentially asking is which of these is caused by a bacterial infection specifically. Okay, so check for understanding. What is a pathogen? Yeah, so a pathogen is anything that causes a disease, like an external agent that causes an infection. So that'd be something like a bacteria or a virus. Okay, so some common examples of pathogens. Once again, there are tons of them in your textbook. You don't need to know all of them. Please make sure you're looking at the read section to make sure you're only reading the sections that are associated with what you need to know for the course. This is a summary. All of the things on this slide are example of pathogens you need to know. So for bacterial infections, there are staphylococcal infections. So that would be like a staph infection. Staphylococcal infections are the most common cause of hospital-acquired infections, such as MRSA, which stands for methicillin-resistant Staphylococcus aureus. You do need to know MRSA, and you need to know what it stands for. Another category of bacterial infections are streptococcal infections caused by streptococcal bacteria, such as strep. An example of a streptococcal bacteria you need to know is streptococcal pneumoniae or S. pneumoniae. That is the most common cause of community-acquired pneumonia, meaning ammonia that someone catches outside of the hospital, so in the community. That's also sometimes called like walking pneumonia. Another specific bacterium you need to know is Clostridium tetanus. Tetanus, this is the bacterium that releases a toxin that causes tetanus. Clostridium botulinum. Botulinum sounds like botulism. So this is the bacteria that causes botulism. Same thing, this bacteria makes a toxin. The toxin is actually what causes botulism. That toxin, botulism toxin, is actually Botox. That's what Botox is short for, botulism toxin. So Clostridium botulinum is also very important because it is how we discovered Botox. So those are all the bacterial infections you need to know by name. Viral infections you need to know. The flu, so that would be influenza A, B, and C virus. COVID-19, of course, which is caused by the SARS-CoV-2 virus. Herpes, which is caused by the herpes virus. Mononucleosis, which is caused by Epstein-Barr virus. This is one that pops up a lot in a lot of other modules because Epstein-Barr virus is associated with a lot of other diseases and disorders. So this is a good one to know. Mononucleosis, more commonly just called mono. So it's caused by Epstein-Barr. And then for fungal infections, like I said, the only pathogenic fungus that you really need to know is called Candida, and it can cause things like thrush, which is a fungal infection in the throat. It can also cause yeast infections, which is a fungal infection in the vagina. And then for parasites, the only one you need to know is malaria. You do not need to know any protozoal pathogens for this course. Check for understanding. For which of these infections would an antibiotic be used? Okay, so remember, antibiotics are only for bacterial infections. So another way of asking this question is, which of these infections is caused by a bacterium? So COVID-19, that's a virus. Candida, that's a fungus. S. pneumoniae, that is a bacterium. And malaria, that is a parasite. So which is the only one which we would use an antibiotic for? That would be C. S. pneumoniae. Okay, and with that, that really is it. Sorry, I jumped the gun there a little bit, but that is it for Module 1. What should you do to study for Module 1? The learning guide, incredibly helpful. I recommend that you use the learning guides essentially as a reading guide and fill out the learning guide as you are doing your reading. Other things, Quizlet sets. I have made quizzes to help you practice specific signs and symptoms. For this week, there's not a lot of signs and symptoms you need to know, so it also is reviewing some of that vocab. I recommend that every week you do the weekly quizzes at least 3 times. In Davis Advantage, you have a lot of those Davis Advantage assignments that are actually really, really helpful. Within Davis Advantage, there's the personalized learning plan, which are just more activities it recommends based on how you do on those assignments. And then, of course, there is the website, the little Google site that has a lot of different links to helpful resources. The Quizlet and the quizzes and all of those other good things are all linked within that Google site. The link is right here, or once again, you can find it in that first Canvas announcement that I posted. Okay. And with that, you did it. Congratulations. That is our first lecture for Module 1. Good luck in your studies, and I'll see you next time.